Okay, we are set. Good evening. Welcome to this edition of Isg PG Masterclass. Today's class is on clinical examination, a very important topic. Usually this is not discussed. We have only one or two classes on history taking and physical examination for each and every batch. And most of the examiners come back and report that the clinical evaluation part of our residents are not as that much expected. Okay, so that means there's a lot of scope for improvement from their side. That is perhaps because the original style of clinical approach to problems are not given that much importance. So we thought that we should give adequate importance to the skill of examining the patient properly, general examining as well as systemic examination. For that, we have Professor Vinay Kumar, who is the director and head of liver unit and transplant center at Global Anandapuri Hospital, Tirunelveli. Professor Vinay has been the long head of the head of the Department of Gastroenterology of Government Medical College Tirunelveli for a long period, and he is an acclaimed teacher, astute clinician, and very good teacher. I would say very good teacher. People who have listened to his class earlier has given me a lot of feedback that Professor Vinay's classes were very useful, especially those on clinical examination. So a warm welcome, Professor Vinay to ISC PG Masterclass. And the four discussants are Dr. Jovida from Medical Trust Kochi, Dr. Pavan from Medical Trust Kochi, Dr. Priyansh from Apollo, and Dr. Dinu Abhirami from Global. I welcome the discussants also. And there are certain house rules. Except the discussants, others, please do not offer answers in the chat box unless you are asked by the faculty. Please. Because the faculty may feel it's bad because if you give the answer before the other discussants are giving. So if the faculty asks you anyone other than the four discussants, you can share at that time your answers. Okay. So over to you, Professor Vinay Kumar, to start your class.
Good evening to all of you. Thank you, Professor Varghese Thomas, Professor Jayanti, and all the dear residents. I'm allotted 4 residents for active interaction, and Dr. Jovida, Dr. Pavan, Dr. Priyanush, and Dr. Dinu. I think you can make yourself visible, and so that you can have an active participation. Okay, so yeah, welcome to all of you.
Thank you, sir.
My discussants and all the residents, in fact, So yeah, we'll go. Yes.
Each of you can keep your in the mute mode and unmute when you are asked the question.
Okay, so that
video can be on all the time.
Okay. I'll just open it again. Okay, the next 1 hour, I will take you to the discussion of the clinical methodology and why is it moving? Yeah, it was moving.
Is the cursor? Just try the right cursor.
Yeah. Okay, now it's moving. Okay, yeah. In the clinical examination, in the exam situation, there are 6 points which we'll be discussing with you. History taking, physical examinations, the differential diagnosis, investigations and its interpretations, management and the prognosis and prevention. So I think this is a general style. And but there's a question, should it change, which in fact we have been discussing, especially during the COVID issue, which we will take it up later. And see the online methods of examinations coming up, and then more of the investigation-oriented approach, etc. And should we accommodate all these things and make it a bit of change in the clinical methodology? I think as of now, this is the way, and we'll take a call later. Okay, so I think I'm told that you have had a session of history taking, and then my job will be to take you through physical examination, the aspect of clinical methodology, which I tell you that it has got three components essentially: a general examination, systemic examination, and examination of the relevant system. So I think these are three components of the physical examination of which, well, these are the general things which I would like to share with you at the outset. The clinical methodology should be taught correctly. So no doubt about that. I think, well, interpretation may be different based upon your knowledge level and experience. Your interpretation may be different, but then examination will be the same. Not just for the examination. Okay, so I think honestly, it's not just for the examination. Every time you should be examining the patient after your this examination also, you should be sticking on the same thing. It's something like driving. The driving rules are the same. Okay, so even if you are driving a Maruti car or a Mercedes Benz, I think the driving rules are the same. The road may be the same, but the rules are all the same. Okay, so I think that is the importance of the methodology. And so I think the first year will be the MBBS students will be doing the same thing. MD students will be doing the same thing. And DM also the same thing will be done. But then the level of interpretation will be different. But the rail is the same. The level of interpretation is going to be different. So I think as you grow in your clinical stature, I think you'll become more flexible, practical, and then you have the capacity to be more customized. So that's the word. This word I'll be repeating again and again, and I would like to impress upon you. The examination, the methodology of examination is not the same for everybody. It's not one size for all. There are 100 types of examination, general examination for a gastroenterology case. So I think that is what I would like to impress upon you. Okay, so I think, well, this is my opening case. I generally, I have discussed this case many times, This, in fact, is a 20-year, probably this case is of about 2005 or so, when I was the head of gastroenterology in Tabata Medical College. I think, well, Jovita, can we have the discussion? Okay?
Yes.
You will be helping me with the case. Okay. So listen to this case.
Yes.
Okay. This is a 35-year-old male. He is referred from Kanjirapalli Government Hospital. Kanjirapalli is a place in the Travancore, is near Kottayam. This patient got himself referred, because he is HbSAg positive. He is symptom-free. But then why he got himself referred? That's because his brother died due to hepatocellular carcinoma recently, and he was HbSAg positive. And another brother died of jaundice and ascites 7 years ago. And then he used to take alcohol, etc., but then his medical records are not that much available. So he was very much scared, and for better care, he got himself referred to Trivandrum Medical College. So he came over there, and then seen by my resident in the OPD. Okay, so listen to HbSAg positive, E antigen negative, AST/ALT 45/42, DNA is 1,800 international units, and ultrasound scan shows mild hyperemia, and the spleen size is 10, no portal vein thrombosis, no spatial lesion or ascites, So I think what will be your diagnosis at this point?
Chronic incidentally detected hepatitis B positive. No definite evidence of chronic liver disease. According to ultrasound, DNA levels are 1,800 international unit per ml. E antigen negative means less of infected infectivity, and according to the natural history of hepatitis B positivity, maybe E antibody has become positive.
Okay, yeah. So I think the resident made the diagnosis maybe say 20 years ago. Chronic hepatitis B inactive carrier. In fact, that was the diagnosis. That was sort of terminology at that time. Okay, so well, I think he suggested that no antivirals are required at this stage. Only close follow-up, but LFT ultrasound scan. That's what is really required. He has reassured him. Okay, but then I would like to. So this is the understanding in 2005. Okay, so I think now I think the understanding is different. If we just look at the ESL guidelines of chronic hepatitis B infection, etc., it divides chronic hepatitis B infection into 5 stages. Okay, Pawan, okay, will you be able to say what are these 5 stages and to which this patient belongs to?
So the 5, good evening, sir. So
Yeah.
the stages are immune tolerant.
Yeah.
Then
I think that was the old one, you know. The currently, it actually classifies into, chronic E positive infection. Okay. E positive hepatitis, that's the first phase. E positive hepatitis is the second phase. E negative infection is the third phase. E negative hepatitis, chronic hepatitis is fourth phase. And then occult infection. So these are the 5 stages of the natural history of chronic hepatitis B infection in the ESL 2017, 2018. Okay. So this, in fact, the terminology at that time. So I just make this terminology, but then I thought, you will object. Because inactive carrier, etc., with the terminology at that particular point of time. And then now you should be knowing the current terminologies. Okay.
Yes, sir.
Yeah. So I think if you are not aware, update yourself. Okay. But then his conclusion was that, the patient needs only close follow-up, LFT, ultrasound scan, etc., are not regulated. I mean, close follow-up with the LFT and ultrasound scan. Okay. That was his. But then the problem was that, this patient was not satisfied. Okay. He was not satisfied, and then he came to me. And he said, I told him why you are not satisfied. And then I just the show, I just the descriptions there, what my resident has actually written. And I also thought that, he was on the correct track. So I asked him, why you are not satisfied? He told me that, doctor, I came all the way from Kanjirapalli, but then I was not examined. Okay, I was not examined. I said that so you should be aggrieved. I agree with him. So I just looked at what the resident has actually prescribed, and I thought it was correct. But then he made the point that he was not examined. So I immediately I called the resident, okay, and I examined the patient. When I examined the patient, I had the shock of my life, and I asked my resident also to examine this patient. Okay, so examination showed that this patient had a large liver, but this liver was firm to hard. So this patient had a firm to hard liver. Okay, and then you could hear bruit and rub also. Okay, and so what is the diagnosis now?
So it can be hepatocellular carcinoma because
the diagnosis is hepatocellular carcinoma at this stage. Okay, look at the family history. Look at the family history. Okay, HBsAg positivity, and what is the outcome like? And this, in fact, is a firm to hard liver, but the bruit and the rub is the clinical. So I think there are many things beyond the ultrasound scan or the biochemistry, which the palpating finger will be able to tell you. And this is, in fact, is an example. And I always tell this story whenever I go for methodology of examination, because without examining, so the patient was actually really aggrieved. I really agree with him. The patient has to be examined properly. The patient was immediately admitted. And sorry to suggest that, the patient succumbed in about 3 to 4 months' time. So he would not have survived for the meticulous follow-up, which in fact was initially prescribed to him. That is 6 monthly ultrasound scan, etc., etc. Okay? Yeah. So with that, it's not moving. Yeah. So I think now we come to the proper discussion. These always after proper history, you examine the patient. You cannot straight away start your examination. You should have an orientation with a proper history. Okay, so you go for general examination, systemic examination, and then the examination of other relevant systems. So I think that is the order. Generally, we do it in the sequential order, but then you can always combine. Okay, so yeah, but then you should be very sure about how to combine that. Otherwise, you should maintain your sequential order. Okay, so general examination, systemic examination, and the examination of other relevant systems in a sequential order. But you can always combine, if you're confident and if you know how to. Okay. Yeah, I think what is this? What is this? And what is the relevant to our discussion? Okay, what is this? This is
because
this is I can tell you the story of these people. When I was taking a general clinics for the MBBS students, a liver-related problem. So he has given me a short history, and which I thought was very, very short for the case. And then he came to general examination. And general examination, he said, "So there is no pickle." I said, "What pickle?" And then he stared at me. And then there was actually a very wonderful expression of the whole class, as if this gentleman is not knowing. He has come to take a class, but does not know what a pickle is, in fact. Then with a lot of audacity, he explained to me that, so pickle means pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema leg. And this is, in fact, a pony which you can keep it in your mind so that you will not actually forget things, etc. Okay? So I find that, this pickle stays with not only for this third-year students, but for MD and even for DNB and DM also, the candidates fail to mature beyond this pickle. Okay, so in the general examination, I find that still people are in the pickle stage. Okay, so even for the MBBS, I thought this pickle is not enough, but certainly not for you. So of the three aspects about the examination, this is my comment, after being an examiner for several years, this is what I found. Systemic examination is easy because it's only for abdomen for you, and cardiologist is, cardiology for them. It's easy generally, but general examination is difficult. And examination of the relevant system, everybody tells about that, but nobody knows how to do. So this is what I found. Okay. And generally should be true for this crowd also. Okay. And why is general examination difficult? That's because, I told you, it's not a pickle. It's not just pickle. It has to be beyond the pickle. Okay. And it has to be customized. The systemic examination is not that much customized. General examination is very much customized. And then you have to complete it in a short period of time. Okay, you just look at the face of the patient and about the lower eyelid and then stare at the patient, and then you do not know. You're just thinking, what to do next. Okay, so this is something which we generally come across during the examination. So it is a difficult thing, generally speaking. So I think, so now, This evening, we'll be talking mostly about the general examination. Okay. Yeah. So, Pawan, will you help me with this, please? Okay. I'll take you to
Yes, sir,
this.
it is.
Okay, sure. Yeah. Listen
Yes,
carefully.
sir, it is.
Yeah, I can read, you can just listen. 72-year-old female. This patient came to me, I think, yeah, immediately before COVID, or just, that is. This patient had ovarian cancer 2 years ago. She had total hysterectomy and chemotherapy, but now, she might do after 2 years, she came with a chest discomfort, heartburn of 1 week duration. Okay. So her ECG was normal. And then she was actually sent to gastro department. Okay, for heartburn and chest discomfort, ECG normal. Okay. And then, well, the first thing that we do, in fact, is a endoscopy. Some gastric erosions were there, ultrasound scan, some gallstones, but no polycystitis. And she was initiated on PPI, proton pump inhibitors, and some prokinetics. Good enough. But the problem is she did not find much of relief. Not only that, she just had an exacerbation with the bulging, palpitation, anxiety, probably after about a week or so. And then the patient went to a cardiologist. The patient was admitted there. Patient had ECGs, which are normal. The TROP2 was negative. Okay, so at this point, the cardiologist took my opinion. Okay. So now, what would be your differential diagnosis? Okay, yeah. So I think again, we should always think in terms of a cardiac cause, because it may be very difficult to exclude cardiac problems, So I think that again should be in the list, probably topping the list. And then other things in the mediastinum. See, mediastinum is so that's I would like to talk about mediastinum. You have a stake in the mediastinum because you've got esophagus there, and so is the pulmonologist. The cardiologist. The mainstay is in the mediastinum, but none of these people they own mediastinum. I can tell you that they don't do a proper clinical mediastinal examination. A proper clinical mediastinal examination is, I think, very uncomfortable for all these specialists. Okay, yeah. So even for the pulmonologist, the cardiologist, they only look at the heart, but then they don't look at the mediastinum. So this patient can have a pneumothorax. Okay. Something in the mediastinum can easily be missed because people are not usually, trained to look at the mediastinum properly. Clinical examination of the media. I will come to this point later, so probably not in this class, but how to do a mediastinal examination. Because I found that many people are not very comfortable or competent to do a mediastinal examination. So I will take you through mediastinal examination sometime later. Yeah, so I can tell you, I can give a one of my like a case history also here. This is I think the story 20 years back. When we used to do a lot of the sclerotherapy. You might not have seen a sclerotherapy now, but that is what we generally used to do for varicose blood, etc. at the time. So there was a patient, a lady with ESPVO. Okay, so she had came with, he had many settings of sclerotherapy, and I had done a sclerotherapy, and she came after 2 or 3 days with the severe chest pain. Okay, so I did not find anything there at the time. I prescribed some antacid that she might just 20 years back, and she came back again, 2 or 3 days with severe chest pain and all. Taken a chest X-ray, which is normal. But then at the time, the CT scan, in fact, is not a very popular thing. I gathered a CT scan of the chest and I found that she had a huge mediastinal abscess. And I have I got the patient to train about 2 liters of pus on the mediastinum. Okay, So it's a mediastinal abscess, 2 liters. Okay, so we cannot actually make a diagnosis by clinical examination, and the chest X-ray was normal. So that is the importance of mediastinum, I'm telling you. So mediastinum can hold many things, with just a chest X-ray be normal and the clinical mediastinal examination be normal. So I think that, so it can be pneumothorax, it can be mediastinitis, okay? Esophageal ulcer, etc. It can be. So I'm just giving some differential diagnosis, okay? So, yeah, so this general examination shows the patient was anxious, patient was sweating, and she has a slight tachycardia. He had, it was not anemic, but then leg edema was there. Okay, so leg edema. So in this context, how will you approach this leg edema? I think you can see that, leg edema. Pawan, what do you find there?
Sir, it looks like unilateral leg edema only, sir.
Yeah, unilateral.
More on the right side.
Yeah. So if you press for some time, you can find on the left side also, but then mostly on the right side. Yeah.
Then we can think about lymphadenopathy, sir, because
is it below the knee or above the knee?
it's above the knee, sir.
Yeah, it's
so
above
any inguinal lymph nodes.
Yeah, inguinal lymph nodes probably.
Lymph nodes that are compressing the lymphatic drainage.
Yeah, I think that is something good, So you need to look at the lymphatic drainage. I have done the examination of the inguinal region, but then no lymph node could be found. Any other differential diagnosis? I didn't see with the previous history.
Venous thrombosis, sir.
Yes. Yeah, I think thrombosis may be another thing, Yeah, sure. Yeah, DVT could be. Who said DVT?
Priyansh, me, sir.
Yeah, Priyansh.
Yes, sir.
Yeah, okay. Yeah, I can see. Yeah, so DVT, I think thrombosis is very important, Yeah, so I think if it is deep vein thrombosis, what is the comment on that, deep vein thrombosis?
So the reason striking was there is a history of malignancy, post-surgery, chemo.
Yeah,
these are risk factors.
Yeah, that part is agreed upon. This patient definitely is a prone patient for DVT. Okay.
Yes.
Yeah. So then, what the type of DVT is patient? You've seen the leg.
Yes, sir.
Yeah.
So the level of lesion can possibly be the common iliacs in this patient, possibly.
No, I think that then the clinical answer, which will be that, a patient with DVT, above the knee and below the knee, there is some big difference. What is it?
The risk for dislodgement is higher in above the knee.
Yeah, come to the point. Dislodgement to where?
Pulmonary circulation.
Yeah, sure. You come to the
pulmonary thromboembolism is high risk.
Yeah, pulmonary embolism. Okay. So the patient has got above the knee, the chance of pulmonary embolism is very high. Okay. So this particular patient, what is Homan sign?
It's on pressing the calf, there is severe tenderness.
That is Homan sign.
No, sir, dorsiflexion, forced dorsiflexion of the palm will cause the pain to the patient.
Yeah, so I think if you do a dorsiflexion, there can be pain of the calf, Okay, it's not a big sign, but that's a sign for deep vein thrombosis. Okay, so in this particular patient, definitely, you have to check for this Homan sign, and then you will be asked to do it. Okay, demonstrate this Homan sign. Definitely. Okay, you may say that the specificity is less, etc. But in this particular patient, where there is no lymph nodes, the chance of thromboembolism, DVT is high. And mind you, the patient presented with something. Okay, yeah, could be suggestive of a pulmonary embolism, you need to look at the for homicide. Okay. Fine. Yes. Okay. And how will you correlate that, you know? In this particular patient, the homicide was positive. So the diagnosis is deep vein thrombosis, high risk, and hence, what is the current condition?
Pulmonary embolism.
Why don't you? So I think you have a level threshold for making the diagnosis of pulmonary embolism because that is a life-saving thing. Okay, so yeah, you can see this CT there, you know, you can see bilateral, okay, more on the side. Fine. Got it? Say something. Yeah, so this is a patient with, what is the diagnosis? The diagnosis is pulmonary embolism, okay? So this patient, the presentation, the cause of the heartburn, the chest discomfort, and the extreme anxiety in the particular patient is pulmonary embolism. So I think here the learning point is that general examination is not a predetermined script. It is not confined to pickle. You need to go beyond that, and then you need to extend your appropriate investigation, examination, and then you should know how to do this extended examination also. Okay, fine. Okay. Now Dino is there. Dino.
Yes, sir.
Okay. Yeah, I think yeah. Now, well, I will take you through another case of an IBD.
Yes, sir.
Yeah. Read it out. 35-year-old female, ulcerative colitis patient on azathioprine and mesalamine for 4 years, now presented with an exacerbation. But 8 to 10 bloody stools, and there's no history of drug default. Okay?
Yes, sir.
Yeah, so the diagnosis comes as
Either
yeah.
Either it could be a superseded infection, sir, like bacterial colitis or viral infection like CMV colitis.
Yeah.
Or it could be a exacerbation of the disease, response to the diseases.
Correct. Yeah, it may be an ulcerative colitis exacerbation that in fact is, that becomes, she is on immunomodulatory, so immunomodulatory refractoriness, or maybe a Clostridium difficile infection, okay?
Yes,
or maybe CMV colitis because this patient is on azathioprine.
Yes, sir.
Okay, so I think these are the differential diagnosis of this patient, okay?
Yes, sir.
Well, I think, yeah, what do you find the leg? You just describe that, you know, and then tell me what it is.
There is an erythematous patch over the leg on the anterior aspect, extending medially.
Yeah. Yeah. And here we anterior posterior. I think we more refer to as extensor and flexor. You know, this is more the extensor aspect. Okay. Yeah. This is just above the
ankle joint, sir.
Malleolus. Medial malleolus.
Yes, sir. Medial malleolus.
I think so. This description should be correct, you know. Then only you may be able to make the diagnosis. Okay. So you may find an erythematous lesion. Well,
yes,
ask the patient whether it is tender or not. It is in the extensor aspect of the lower limb above the medial malleolus. Okay. So if you just hear this description, you know, what could be the diagnosis?
First is whether there's tenderness or not. We'll have to know, sir.
It hardly matters, you know, here, because this lesion can be tender or non-tender. I was just telling you, but then this lesion can be tender or non-tender. Priyanush, what is your diagnosis?
Erythema nodosum.
I think at this stage, there's not be any problem, you know, you have to make the diagnosis of erythema nodosum. Okay?
Yes,
yeah.
Sir.
Yeah, it should be reddish, peanut-like, okay? It should be firm, subcutaneous, okay? it should be swelling also there. Okay, if you palpate that, you know. Okay.
Sir.
Yeah, it's a erythema nodosa. Okay, so description you should be knowing, and we generally feel that because of the skin color, etc., we don't find the erythema nodosum here. It is not correct. If you look for that, you will find many cases of erythema nodosum. Have you seen erythema nodosum in your clinical practice?
No, sir.
Oh, you have to. You are missing. Others? You have seen, yeah.
Yes, sir.
What are the? You just give me some conditions where you can find the erythema nodosum.
In leprosy also you can get.
Leprosy, but you hardly see leprosy these days.
TB, tuberculosis is.
We used to see, yeah.
These are the two ones that I can think of, sir.
Any other causes for because erythema nodosum is a fairly common
rheumatic heart disease
in many conditions, you know. But then you need to know the differential diagnosis. At least half a dozen conditions you should be able to tell me. Yeah, it may be seen in the case of the classically in the case of rheumatoid arthritis.
RHD, subcutaneous nodules.
Rheumatoid fever you should be able to see. In the case of infectious mononucleosis, you should be able to see. Sarcoidosis is a classical lesion.
Sarcoidosis.
Okay, and then there's drug allergies are there. They should be there. IBD, you may be able to find. So I think there should be, so this is a very common question, you know, list of erythema nodosum. So I think we'll not be satisfied with anything less than 6, okay? And it's a common finding also. And if you are not seen in your clinical practice, definitely you should be missing and you should be looking for these lesions also, okay? So I think I will take you further in this particular lesion because you need to get familiarized there. So there are other areas also you should be looking for. This is the extensor aspect of the forearm. These are all erythema nodosum cases, okay? Yes, you may be able to see that. And then over the elbow, extensor aspect of the elbow, you should be able to, so you should be looking for these areas, you know. And the back also, the interscapular area also, you may be able to see, okay? Yes, and then sometimes, you know, it becomes extensive. That is the classical one which I have shown you. And sometimes it becomes very extensive, you know. Okay, so this again is a case of erythema nodosum. It's an extensive one. So what should be the differential diagnosis now?
Erythema multiforme, and if it ulcerates, then pyoderma gangrenosum.
No, I think you can look at this and then you can give me the differential diagnosis. This is an extensive one. Extensive. This case is erythema nodosum, but then differential diagnosis should be there. Suppose the patient is diabetic, you know. Necrobiosis.
Diabetic heart.
Diabetic heart. Okay, so that is a classical differential diagnosis for this. And sometimes, you know, you can get ulcerated, you know, mild ulceration, infection. So what will be your diagnosis right now? What do you say initially?
Pyoderma gangrenous.
This is not gangrenous. It can be a cellulitis, you know.
Yes,
okay, yeah. Gangrenosum is actually gangrene. There is no gangrene there. Okay. Now you can see that there's a gangrene there. Okay, so this again is not a pyoderma gangrenosum. This is an erythema nodosum itself with a necrosis here. I've shown you different stages of erythema nodosum, but the different differential diagnosis. It's not easy sometimes. So here it may look like that of a pyoderma gangrenosum. Okay, how you distinguish between pyoderma gangrenosum and erythema nodosum? Because the understanding will be different. The treatment is going to be different. Okay, yeah.
Distribution of the lesions.
How will you?
Distribution of the lesions and pyoderma gangrenosum usually larger lesions.
No, I've seen, I've shown you, this is a large lesion.
Pyoderma gangrenosum usually starts as pustules, which then coalesce and ulcerate, and then there is necrosis.
Okay, but then now at this particular stage, what should you do? What you should do, in fact, is biopsy. Okay. And biopsy, what is the biopsy of erythema nodosum? Erythema nodosum basically is a paniculitis. What is meant by paniculitis? Adipose tissue inflammation. Okay. Whereas pyoderma gangrenosum is actually gangrene. There you can find gangrenous necrosis, but thrombosis of the vessels also you can find. Okay. So you need to distinguish these conditions, okay, by biopsy, by doing biopsy. Okay, fine. So I think, well, biopsy really is really required to distinguish even erythema nodosum from pyoderma gangrenosum, if you look at different stages and all. So here, well, what is this is an erythema nodosum. So what is likely to be? Erythema nodosum is associated with exacerbation of ulcerative colitis. Okay. So your diagnosis is likely to be immunomodulator refractory exacerbation of ulcerative colitis.
Yes, sir.
Okay.
Yes, sir.
So the learning point is that, observations need to be meaningfully interpreted. You have to have a higher interpretation of the observation. Okay.
Yes, sir.
Yeah. And then you can definitely give some insights into the clinical cases. Fine. I will take you to another case. Okay. So, yeah. Yeah. I think we're going to, do you know? Jovita?
Yes, sir.
Who is Jovita?
Yes, sir. Yes, sir.
See you. Okay, you are there. Okay. So I think, well, we'll start our discussion with Jovita. Is some problem with the connectivity?
Jovita, your camera is not on.
Hello, can you it's on, sir. Video is on.
Okay, fine. Okay.
I think probably, okay. I'll ask some questions to you. You can be with me. Okay. Yeah. And then if there is problem, probably I can pass it on to others.
Yes, sir.
So this is the case of this case, it's about 40 years back. When I had my GA training, and then soon after that, probably more than 40 years ago, then this is in Alleppey, again Mitra Vancouver, and not much of investigatory facilities there. The whole district, there was no CT scan. Okay, you may find it difficult to believe, but I think, now we have a lot of comforts of investigation right now. Okay, so look at the case. So this is a 20, but still it is relevant. That's why I keep on giving you this. Okay, yeah. So, yeah. So this is a 24-year-old female, 3 weeks after marriage, developed abdominal pain and hematemesis. I think now it should be poisoning and all now, with a lot of news in the newspapers and all. Yeah, but then history is that she had taken NSAIDs, non-steroidal anti-inflammatory drugs for the right knee pain. Okay, and then she had endoscopy done. We showed some extensive gastric erosions and all. And she was given proton inhibitors and antacids. Okay, so maybe probably is 2 blockers at the time. So I think that is the case. Okay. Yeah. So what is the diagnosis, Jovita?
Yeah. Gastric erosions, extensive erosion.
That's okay. But then I will ask you this. Well, she had knee pain and then NSAIDs. Why should she develop a knee pain?
Maybe some urethritis, arthritis
Oh, yeah, urethritis and arthritis. Okay, that's a good diagnosis. Urethritis and arthritis. Good, good, good. What do you call that?
Yeah,
this is a honeymoon urethritis and Reuters. Yeah, that may be a good. Reuters. Okay, maybe a Reuters syndrome. Okay, she has got the components of that. Then Reuters. So I think, remember, you have that sort of a diagnosis. So Reuters, and then these non-steroid anti-inflammatory drugs, and then she had a gastric erosion. So it becomes a better case. Okay. Okay, it's good. Yeah, but the point is that, you know, 5 days later, she developed severe abdominal pain and then even gaudy. Okay, and amylase lipase were normal, and then she underwent an exploratory laparotomy. That's the point, because, you know, there's a practice at that time. No CT scan available. You know, you can't actually think about this eventuality now. This patient, okay, and exploratory laparotomy, but then what is the cause of that? What is being suspected there? Jovita?
Any ulcer perforation.
Ulcer perforation, DU perforation, correct? Yeah, perforation. But then they did not find any DU perforation, no bowel perforation, only some congested and edema at the small bowel. That's what was seen. Then severe pain continued, you know. So I think, and then the patient was in fact referred. So I saw this patient at this point of time. Okay. Yeah. So yeah, what do you find there?
Right knee swelling.
Yeah. So I think yeah. So I think the beautiful legs of a young girl, and some slight right leg swelling was there. Okay. Yeah. The question is about what else will you look for? What else? Pardon?
Look for knee joint tenderness.
Okay, now, Pawan, your thoughts.
Sir, we need to see other systemic involvements. It can be, as a young patient, connective tissue disorder involving GI vasculature.
Okay, yeah. Prenatal, your thoughts.
Ophthalm, the eye I would like to see for conjunctivitis.
Conjunctivitis.
Urine examination, I would also want to see for a urine examination.
Conjunctivitis will take you with what?
With the diagnosis of so reactive arthritis, conjunctivitis, and urethritis, the triad for Reuters.
Yeah, but then we are dealing with abdominal pain.
So vasculitis can present with yes, small vessel vasculitis.
Yeah, so I think, well, this is the back of the, you can see the back of the thigh, the buttocks and all.
HSP.
Yeah, so I think the clinical points for henophilium purpura. What are the components?
Abdominal pain.
Yeah, abdominal pain.
Joint pain. Joint pain.
The voice is breaking. Yeah, abdominal pain, joint pain.
Purpuric spots. Purpura.
Yeah.
And hematuria. Renal involvement.
Renal involvement. Okay, I think, well, what about Priyanesh? Priyanesh, can you take up the next questions? You know, so I think, well, she's not well audible. That's why. Okay.
Yeah.
Okay. Yeah. So I think, well, what we have mistaken initially for Reuters, in fact, maybe an HSV. Okay. Okay, HSV. Okay. Where is Rihanna?
Yes, sir.
Yeah, you can, yeah. You can give your opinion. Okay, fine.
Yes, sir.
So there are 4 points, abdominal pain, then renal involvement, okay, joint pain, okay, and the purpura. Fine. In the case of, purpura, it may be painful, palpable, and proximal purpura. It may sometimes only be seen over the buttocks. So you should be careful about that. Only the proximal thigh. Okay? In the distal, it will not be there. So that's the distribution. What about the joint? Large joint, oligoarticular. Okay. Okay?
Yes, sir.
Yeah. So I am giving another situation here. So this is a young lady. Suppose there is actually middle-aged lady, say 40, 45-year-old lady, presenting with the purpura, which is smaller purpura, distal in distribution. Okay, maybe in the ankle, maybe in the toe. And the joint, in fact, is polyarthritis. It is here it is oligoarticular involvement. There it is actually polyarticular, small joints involved, just like rheumatoid, and present with abdominal pain. The same components, but different types. What is the diagnosis?
So, slightly elderly, it couldn't be a component of Raynaud's.
I think it's a classical condition. I'm just telling you. Here, this is classical for HSP, and there it should be classical for, again, abdominal pain. Again, it's another vasculitis, What is this vasculitis I'm referring to?
Not sure, sir.
Owen?
Not sure, sir.
It can be, again, associated with, again, hepatology, I can give you a clue. I think you're valid. It is associated with hepatitis C virus infection, speaking.
Cryoglobulinic vasculitis.
Yeah, cryoglobulinemia, essentially mixed cryoglobulinemia. Okay. Yeah, so I think now we hardly see cases of hepatitis C, but then we have seen cases of cryoglobulinemia. Okay. So I think, well, if you see one component, then you have to look for other components. So I think that's why. So general examination that way. See, here you should suspect a case of HSP. Then only you'll be able to look. So you have suspected this Repair syndrome, and you're looking for this conjunctival involvement, etc. Is correct. But you have predominant involvement is abdominal pain. So you need to consider vasculitis, a thing, abdominal involvement, and then you have to suspect an HSP here. Okay. And then you have to go for extended examination. The buttocks, the proximal thighs are not the usual size of your general examination. But in this particular patient, you need to extend your examination based upon your clinical suspicion. So if you find that, so it's a real case. You find that the diagnosis is there. Suppose you found it about a few days back, you could have avoided a laparotomy. I keep on presenting this case, because I keep on seeing such patients. Even about 3 months back, I have seen a referred patient this way. Abdominal pain, young patient, and then eosinophilic purpura. The problem there, in fact, is that, the purpura is proximal. It's not in the usual size. What you see in the leg, in fact, is the distal part of the leg, So here, unless you look at the proximal and that too in the extensive proximal aspect, you might miss the lesion. You got the point? That's why I'm telling you, it should be customized, Okay. So I think I will just yeah, so I think we'll go for the concluding part, because I'll skip other cases, etc. We'll come to the conclusions, etc. So there, I'll tell you that how to do the general examination properly. So I think you should get an orientation from a history. You can't just embark upon, seeing the patient. You can't just start off the examination. You should have an orientation. And you need to, with the history, you need to have a formulate some differential diagnosis. And then you should have an enumeration, what I should be looking for. The examination first, then you should have formulation, I'm going to look for, there should be an enumeration. I'm going to look for these things. And then you should. It's an active process. It's not just looking at the patient, and then finding out certain things and noting it down. You're looking for certain things. So that's something which I'm emphasizing, It should be customized. You should be looking for certain things, in the general examination. And you should have an enumeration with you. For example, all these cases, unless you actively look for, you will miss these lesions. And that's why.
Also, when you got some more clinical scenario, no, we can continue up to 9:30, no issues.
I know, but then I may take another 14 minutes for the conclusion. That's why. And then we should have some these discussions from these people also. They may be asking some questions. Don't worry, we have some. After some time, when I get some time, then we will have more discussions.
Yeah.
Otherwise, I'll rush through this conclusion. That's why.
Okay, fine. Yeah. Please continue.
Thank you very much. So, how to look for? You should follow the standard methodology. That's very important. It's not just looking for jaundice, anemia, etc. But then you need to know. In a relevant case, you should know how to do a Homan sign. You should be able to. So I think that the methodology you should be knowing. So somebody was telling me this is acute squeeze in the calf. No. Okay. So you should have an extended ammunitions for your general examination. You should be ready for that. Okay. And when you find the relevant observation, you need to follow that trail. And then how to present the observation. So this is very important, There are those findings which you have anticipated based upon your differential diagnosis. For example, you have got a cirrhosis liver. You found jaundice, anemia, and then leg edema, etc. So these are the things which you are looking for in your enumeration, and you are presenting that way. Okay? So that you should be presenting. And then there are some observations which are not anticipated. But you find that. But you can be able to correlate. And that will even modify your differential diagnosis. And that comes next year. Okay? I will give an example, This is, mostly you will find in this, these scenarios in MRCP examinations and all. So, during an MRCP examination, okay, I can tell you the story. There was a lady. I was with an abdominal case at the time. So this lady, he presented the instruction given is that this lady is presented with abdominal distension and discomfort, like edema. Okay, examine. So this is the instruction given. Okay, so general examination. Okay, so this lady was had pallor. And then some pigmentation of the face was there. She had leg edema, and then a very obvious the abdominal distension with an umbilical hernia also. So I think that was the case. And she was wearing a shorts and a shirt with the sleeves actually rolled up to say the elbow. So that is how the patient was actually kept. She was lying down. The candidates, and in one go, there may be 10 candidates. And the candidates, they have examined the patient, examined the face, the hand, the leg, and then they went to abdomen. There probably maybe about grade 2 to 3 ascites is also there. And the diagnosis of cirrhosis liver, both ascites, liver failure, etc. Okay, and one candidate, she checked the arms, she rolled the sleeves further up. Okay, and found that, you know, she had a AV fistula, active AV fistula. What does it mean?
Could be lupus nephritis in this patient.
Pardon?
Could be lupus nephritis or...
Yeah, with the active puncture sites also. AV fistula on the right side with active puncture site is on the left side. With active puncture site is, oh my goodness.
Chronic kidney disease for dialysis.
The patient is on dialysis, you know, the patient is on dialysis. Okay, so this is a case of chronic renal failure, dialysis, and dialysis resistant. Okay, so that's the diagnosis. This ascites is dialysis resistance. Diagnosis is not cirrhosis liver. Diagnosis is here. Okay, one candidate was seen at MRCP marking, etc. You know, that the candidate will be given full mark, you know, and the other candidates never more than 50%. And mind you, the pass mark may be 75%. Okay. So you may find some points in the examination, maybe not anticipated, but that will take you through a different strong diagnosis. You got it? Okay. Yeah. And then mention those observations which you expected but did not actually find. Say, for example, in the case of cirrhosis liver, there is no flapping tremor, there is no dubutinous contracture, etc., or no spiral angioma, etc. You may be able to find. And then mention any observation, even if the relevance of it is not clear to you at a particular point of time. I can give an example. This is again during an MRCP examination. Okay, so this lady, the candidate, the patient had jaundice, mild jaundice. She had a lot of spiral angioma and palmar erythema, and she had ascites and a firm irregular liver. Okay, so that was the case, mind you. And but generally people made the diagnosis of see some of the women there, you know, they drink like fish, you know, so you may be able to alcohol liver disease is not uncommon. And now we find here also alcohol liver disease in women. So you may make the diagnosis of alcohol liver disease there. But this patient had an artificial eye. Right or left, I don't remember, you know. This patient had an artificial eye. Okay. So what does it mean? An artificial eye. What could be a diagnosis? What artificial eye? Artificial eye is enucleation.
Yes, sir.
Is a melanoma. Oh, is it such a big question? Melanoma. Okay, melanoma. So melanoma, metastasis. Okay, malignant ascites, metastasis. Okay, so I told the chairman that, you know, I told the chairman this is, you know, it is not fair examination. If you say that this is going to be malignant melanoma, and one has to be realistic in your discussion, you know. I feel that this patient has got a cirrhosis liver. So I think cirrhosis liver should get the maximum mark. And then, so one should be realistic. The cases should be realistic. And then he stared at me and told me that, Dr. Kumar, see, we are being realistic. This is a case of malignant melanoma. But she was operated for that. And currently, what she has got is a metastasis. That's the real scenario. And then to my surprise, you know, I found that, you know, all the candidates there they noticed this artificial eye, and all of them, they made the diagnosis of malignant melanoma and metastasis. And none of them, to my surprise, none of them made the diagnosis of cirrhosis. So that is, in fact, that is shocking to me as an examiner at the time. Okay. So this is actually several years back. But I can tell you the story, what happened about 6 months back here. I mean, 2 months back here in my practice here. So a lady was actually referred to me from RCC. Okay, so she was referred with an obstructive jaundice. So she had a big gallbladder jaundice and then a pancreatic mass. So I think what they have asked for me from the RCC is that, you need to have a stenting of this patient, okay? And then you need to get a US-guided biopsy of the pancreas. Okay? So that was the instruction given to me. And going into the history, this lady had a malignant melanoma of the toe, okay, which was disarticulated about 7 years back. And 3 years back, she had some inguinal recurrence, etc., and block dissection done. And then the patient is on RCC follow-up for 7 years for malignant melanoma. Okay, so the patient came to me. And we have done a US-guided biopsy. And the biopsy showed that the patient has got a malignant melanoma secondary, metastasis of the pancreas with the malignant melanoma. So I think, well, we are beginning to see such cases also here. These patients are living longer and they are coming with a lot of metastasis elsewhere also. So I think now, again, I had a shock there. So I never thought that malignant melanoma will be surviving this way, etc. So I think, well, I can tell you. So these are some of these, standard base by which others will be looking at the patient, and trying to make diagnosis. So I think how to present the observations, you have an enumeration, you should be looking for certain things, and if you find positive, you have to give first. And secondly, you found certain unexpected things, but then you will be able to correlate them nicely, especially it's a game changer for the diagnosis, you present that with due importance. And then mentions those things, points, which you have anticipated, but you did not actually find. And then some seemingly important points, but the relevance of which you are not able to notice at this particular point of time, that also may be noted and should be actually presented. And then probably in this part, artificial eye, etc., somebody is asking, you may be able to answer that as well. So some of the common mistakes also, and not getting properly, again, I am telling you, it should be highly customized. Okay? It's not casual, it should be customized, but the proper history. And it is an active process, it's not passive pickle. It's an active process. You should have a checklist with you, and each you should be looking for. And then you should extend your examination also, and that you should be knowing. It's not just for lymph nodes, etc., etc. You should be able to look for, say, epithelial you should be able to look for. Pyoderma gangrenosum, you should be able to know how to look for that, and Homan sign. So all the related points, you should know the methodology of examination. You should be sure about that. And wrong methodology. So I think examination be not purposeful. We have seen the patients just staring at the patient, and then stroking at the forehead of the patient, and just thinking about what to do next, The scenery which we often find. Wrong methodology, improper position, inadequate exposure, For example, in the case of Genopsodium purpura, you just go up to the knee and not above that, So if you have the differential diagnosis, you should be able to use it. Ask the permission of the patient, and then you should be examining the patient further. And a back and forth examination, inadequate is back and forth. This is very important. So you start from the head to foot, and then again you go back to the face, So back and forth examination, shuttling, back and forth is not permitted. Non-meticulous inspection without a definite purpose here. You just look at that, see, look at this erythromanodosum. And then you poke it there, and then for some time, purposelessly. You don't know what to do, but then you are touching that, pressing, etc., etc. No. The examination is proper. Okay? You're not looking for tenderness, you're not looking for mobility, you're not looking for a firm mass, etc., etc. You're not looking for the lymph node, corresponding lymph node. So it's not purposeful. You're just poking around that. Okay? And serious omissions are not taken. See, these are very important aspects, but then we find these omissions. Not taking the BP, not examining the mouth and tongue, or even the fundus in relevant cases. In this, you made the diagnosis of retears and all, but then you failed to examine the conjunctiva properly, and then afterwards you tell that I will be looking for this, etc., etc. You did not look for that in the opportunity given to you. Okay, so lack of skill and knowledge for critical observation, interpretation, and understanding. So in the case of, so for example, if in this erythromanodosum, if you tell some other differential diagnosis, well, that is not acceptable. You should have the skill and critical observation power to make the diagnosis, and then say that, oh, this is erythromanodosum. Yeah, it's not giving a differential diagnosis for that, that is not good. Well, I used to start off from there. This is erythromanodosum. So I think with that, the take-home message will be that, okay. So principle one is actually should be customized again, I'm emphasizing that it should be customized. Okay. But 2 or 3 examples I have driven from this particular point. It has to be customized. At the MBBS level, 3rd year level is only pickle. Okay, but then you should go beyond the pickle and you should be able to do a customized examination now. Okay. And make a differential diagnosis in mind. And there should be a sequence. This sequence should be a head to foot sequence, or generally speaking, what is appreciated is a hand to head to foot. That's a correct sequence, It's not just a head to foot. It is hand to head to foot. That is the best sequence. Okay. And then there's no back and forth examination. Okay. So each point, you should settle. Okay. You should be confident. And then it's not going back, etc. You should settle it there. Okay. And keep on looking for a trail for further observation. When you find a leg edema there, okay. And then go for the inguinal examination. It's important. Inguinal examination. And when you find you look for a Homan sign. Okay. And see, when you find some abdominal pain and arthritis, go to the proximal thigh examination also with the permission. Because that is what is required. Abdominal pain, oligoarticular involvement, and the next is in the skin. You have to look for that. Okay, so you should have orientation. And take a note of anything unusual, and try to understand the significance. Okay, as in the case of, I told you about this artificial eye story. Like that, in practice, you may find such unusual things which you are not able to correlate, but then probably you may be able to correlate at a different stage of your understanding. So I think, with this, I will stop the discussion here and for the comments of the faculty, and then you may be able to ask me questions also. Okay, so I would like to leave some time for you. Okay, so that's why I want to stop on time.
Thank you, Professor Vinay Kumar, for that wonderful class. I'm sure every student would have appreciated the class very much. It was such a great class, especially the case scenarios followed by the findings. Jayandima, please give your valuable remarks.
And nothing to beat Dr. Vinay Kumar's discussion on general examination. It's just phenomenal. And every time we listen, we keep learning more. So for me, it was just learning more and more from you, sir. I was just this thing was, in fair people, we can pick up most of these signs. But once they are from down south, Sometimes we find, the purpura and all the erythema and all, sometimes we're not able to pick up that. So any comments on that, sir?
Yeah, I made the comment initially itself,
Yeah.
Even the dark skin, we will be able to.
Okay.
Please look for that, we will be able to find erythema nodosum. And often the patient themselves will be pointing these lesions to you. This is a bit painful, painful. And you just look at very carefully and then palpate. There is actually from peanut lighting there. And you may be able to make the diagnosis. Definitely.
Yeah, absolutely.
Yeah, definitely.
And I think sometime whenever you can find time, I think we need a little more discussion on this. Few things like JVP, pulse measurement. The questions go down to such basics. Such basics like looking for JVP, how do you position the patient, which wave do you look for? And once they falter on that, that's the end of the story as far as the clinics are concerned, because the basics are not strong, including postural hypotension. So I think, so at some point, we would like you to just highlight on the mechanism, the pathophysiology, and then positioning the patient, and then all these fine tuning of these subtle points, including some eye changes. Probably you can take up one session on eyes, xerosis, conjunctiva, pinguicula, xanthoma. So, these things are usually just passed off. As you rightly said, sometimes incidental findings have to be picked up and mentioned. Even if I remember a case of C. esophagus in SGPGI, the actual patient had burns, from a lightning, and the candidate did not examine the back because he was focused on the dysphagia and the corrosive injury. But the examiners said that you cannot miss such gross findings. So, as you said, incidental findings have to be picked up. Head to toe should be a real detailed examination. So I think sometime we would definitely I would definitely like to hear from you on this few things, JVP, pulse, and eye changes, especially oral cavity. The skin was beautifully described. You really picked up very well on that, sir. Thank you so much, sir.
Madam, thank you very much for the input. That's why I told you. The general examination followed by systemic examination will be very much okay. And then the examination of the relevant system. That's where this JVP, etc., will be coming to the gastroenterology, And that is a very difficult area. That's a very difficult area. But then we need to have these interfaces, that is where the interfaces are there. The liver neuro interface, liver kidney interface, liver endocrine interface, liver rheumatology interface. So I think if you want to be a good specialist, you need to make your interfaces very strong.
Very has to be very strong.
The cardiologist, he knows about cardiology, nephrology, about hardcore nephrology, but nobody is strong on interfaces. When it comes to interfaces, there's poor understanding. Well, I think we should be, gastroenterology is such a beautiful subject that, we can explain all things, rheumatology, hematology, nephrology, everything we can be able to.
Gynecology, ENT, everything.
So I think we have to make, if we make our interfaces very strong with our general medicine connections, it will be very wonderful.
What really happens in the exam, even recently, they go straight to the abdomen. They go straight to the abdomen examination. And one such examination, I keep telling her, dextrocardia was missed. And the patient went on saying the candidate said liver is palpable on the right side and spleen is palpable. The whole thing was actually a dextrocardia. So they take it for granted. Maybe it's the stress of the exam. I do not know. But whatever be the stress, I think at the point of examination, I think you want to assess in the times of stress how well they, and I think if they practice every day to day, there should not be any problem at all. If they see that many cases, 100%, they'll be able to pick up even these subtle changes during the examination.
Yeah, in the case of a dextroversion, suppose the patient is presenting with an appendicitis, with a pain on the left side, I think you can't actually miss it, saying that.
They call it as diverticulitis.
Diverticulitis,
Natural to be appendicitis. Dr. VT, your comments.
Shabina ma'am, is Shabina ma'am there?
I don't think.
I thought Shabina ma'am was there earlier. Shabina ma'am, are you there?
I didn't see her recently.
Okay, just such a nice thing, and especially for the exam going student and for your life, clinical practice also, that the way in which Professor Vinay told, the things which you anticipate in a case, when you have a list of differential diagnosis. Okay, that is one thing, things you observe, then things you anticipated and did not find. But what I generally find is a rhythmic sort of, I say like a poem, they will say no, all possible negative things. And actually that will add to more questions. Because at the MBBS level, perhaps if you say no parallel, no sinuses, no clubbing, and make it a sort of litany of things, it may be appreciated. But at DM level, we expect you to be relevant negative. Yeah, relevant negative is very important. Irrelevant negative, if you say, you will be caught. Because they will ask you the need for telling that. Okay, don't unnecessarily bring in. So the Professor Vinay was given that very great detail. You usually find and anticipated not found. Okay, and the other two. Okay, very good.
Yeah,
very good way of
like
saying. Professor Vinay, we expect some more class from you. And whichever day it is convenient for you, we will be happy to have the class.
Yeah, we'll push it.
Can we get some comments from the students now?
Yeah. I think the students, the 4 people who have actively participated, plus those of who want to ask any questions can put it in the chat box.
Okay. Or they can show off and then they can.
Show off hands and then you can from your reaction side, and then you can actually unmute and say anyone.
Yeah.
All quite.
If you have any doubts regarding how you should do in certain situation, the examination, etc. Most never you have examined without having examined. That's very important. You have to be truthful to yourself. Second, when you are asked to go and examine the patient again, that means there is difference between what you found and what the examiners found. I would say generally accept that, go and examine. Never ever say, no, I need not examine again. At least for heaven's sake, to respect the examiners, please go and examine. Okay, because there will be some difference of opinion between what you have observed and what the examiners have. So given a second chance, you should always take that opportunity and go and examine again. And the method, someday they may be trying to find out your methodology of examination. So the methodology has to be perfect. You cannot go to the left side and examine. You cannot be very rough with the patient. You have to be sufficiently gentle. Undressing of the patient should be with permission, and there should not be public exposure. There should be sufficient privacy for the patient. All those aspects also will be observed. Somebody has asked a question, sir. What was that chat in the chat box?
Yeah, so I think somebody is asking that, why HCV, cryoglobulinemia in HCV, HBV, etc. So that is not clinical questions, I think here we will be discussing clinical questions, which you may be able to find out yourself, The clinically relevant question, you make yourself visible and ask the clinically relevant question.
Yeah, not the theory.
So, the gallbladder bit, sir, you really explained in great detail. There's a question on this gallbladder. You can comment on that? Gallbladder.
Gallbladder, what, madam?
The question is that we examine from the foot end how to pick up on inspection. Gallbladder.
Yeah, so madam, this is about general examination.
Yeah, I know. I knew that you were concentrating on general examination.
General examination, then we'll discuss about that,
But
so
you can just tell a few words, sir, because you always mention, start with the foot end, just that bit, sir, because there's a question on that. We have to go to foot end and should we bend ourselves or something?
No, I think I did not read the question. What is the question?
Can I just follow? We have to go to foot end and should we bend ourselves to patient height or not? A great confusion for the method of examination of gallbladder.
What confusion? A great confusion with that.
Confusion.
They want to know whether they should bend to the level of the patient.
That's all. Yeah. How to examine the gallbladder.
We have to go to the foot end and should we bend ourselves to the patient height or not? Okay. So I think, I can answer this question, I think.
You're always good at that.
Yeah. That's because, these are all very important for, the membership exams and all this is very important, examination for the abdomen, examination of the abdomen, you ask the patient to lie down. Examination of the abdomen is always in the lying down position. Okay. And then exposure. The male patients, ask the patient to take the top off, and female, then relevant exposure with the permission, and then extend the exposure again with the permission of the patient, and then expose the standard exposure up to the knee. Okay, and then there is no pillow also. We don't come in the MRCP examination. The patient should be lying straight without any pillow also. Okay. So that is the position of the patient. And then what will you do? First, you will come to the foot end, okay, foot end, and have an examination. So this time, you have a general examination of the patient and an examination of the tummy from either side. Okay, now you are going to come to the right side, But before that, now you have got a neutral view. You will be able to see the left side and the right side. Okay, so I have an examination from this side and ask the patient to take a deep breath, etc. And then come down to the right side. Okay, and then right side, what will be a position. Okay, and there the view should be, at the level of the tummy of the patient. That's very important, You can't actually stand and then look at the patient from above. Okay, so this examination should be at the level of the tummy of the patient. For that, you have to kneel down on the floor on the right side of the patient examine. Okay, so this is very important, Unless you kneel down on the floor on the right side of the patient, see, this is actually a prerequisite for passing the examination in MRCP. So if you stand, you will not pass the exam. I can tell you. The examination of the abdomen, in fact, is you kneel down on the right side on the floor and tangentially examine. Okay, and that's how you inspect, and that's how you palpate, etc., etc. That's one point. And there, I always thought, is it really required or not? But I can tell you that, all the pulsations, the bulges, etc., you will be missing, if you just take your position above, and unless you make your view this parallel, you will be missing it. You may try it. You can find that, you'll be finding out a lot more epigastric pulsation. If you are not seeing the pulse, see these epigastric pulsations are there. See these aortic, aneurysms are there. And if you have not diagnosed the aortic aneurysms, well, I think because your examination is improper, that's why. And then the next thing is whether you have to ask the patient to bend the lower limbs, okay? Or the legs up, okay? Bend the legs up, It's really not necessary, Especially it is not necessary when you examine the upper abdomen. It's not really required. Might be sometimes helping. You have to take it on case by case basis. And then you have to ask the patient, well, will you bend it for some time, so that I can examine it again. So sometimes if there is some stiffness, etc., you may be able to, the lower part of the abdomen, not in the upper part, okay? And then generally, no bending of the legs. And then ask the patient to take a deep breath, This is something which I find very, you won't be able to take on deep breath in and out for the entire exam. It's not possible. It's not really required, Those areas which are actually organs which are moving with the respiration, maybe the liver, spleen, etc., are not in the lower abdomen. So if you palpate on the right lower quadrant and ask the patient to take deep breath, etc., it may not be making much sense unless you palpate the liver there itself here, so such a big liver. So keep on asking the patient unnecessarily to take a deep breath in and out throughout the examination is not really required, in fact. So ask the patient to take deep breath, only when you examine the upper abdomen, okay? And bend the leg if you really require, in the lower abdomen only. So these are my general comments for the abdomen. General exam, I think this is very easy, for abdomen. But for general examination, very difficult, Each of it has to take its own course. For example, if you find the erythromanodosum, you know. Then you have to combine everything. Immediately you have to palpate there, you know, and then you have to go to inguinal area, lymph nodes examination, and then again you have to examine the hands, etc., and then on the scalp. So you have to do it at that particular point when you find that, you know. So whenever you find an examination, a point, you know, then you should know how to extend the examination accordingly. And arthritis you find, you know, then you should go for an arthritis examination. Okay, so that is difficult, I'm telling you.
Okay, that was wonderful. Great, a great class. Dr. Jerry, for the formal vote of thanks.
Thank you, sir. Yes, sir, I'm online. On the behalf of residents, I would like to extend our sincere gratitude to Vinay Kumar sir for joining us and guiding us through the very relevant points in general examination in our cases. We also thank the faculty, Jayanti ma'am and Vagisom sir for joining us through the discussion. I also thank the Isg K office bearers for giving us this platform. I also thank the participants for today's case, Pavan, Jovida, Dinu, and Priyansh for joining us. Thank you.
Thank you. Good night.
Good night. I look forward to some more classes. Okay. See you.
Bye-bye.
Good night.
Good night.
Bye.
Good night. Good night, sir. Thank you, sir.
Bye-bye.
Thank you, sir. Thank you.
I am ending. I am closing the class.